not sure about all of you. It looks pretty full in here, but I can tell you that we're incredibly excited to bring you the efficacy and safety results from our phase 3 trial of Donanemab in early symptomatic Alzheimer's disease. My name is Mark Minton. Here are my disclosures. Probably the most pertinent one is that I'm an employee of Eli Lilly. I head the neuroscience research and development. On behalf of the presenters, I want to express my and our sincere gratitude to the patients and their families for participating in this study. We know that every hour for them is precious, and every hour that they volunteered to be part of this study meant something, and we were incredibly thankful that they participated. We, of course, acknowledge the huge amount of effort of teams at Lilly, who put the slides together, who analyzed the results, who vetted it, and of course our many, many vendors who made it possible. But of course, we couldn't have actually collected any data at all without the site investigators. This study was done over 8 countries: Australia, Canada, Czech Republic, Japan, Netherlands, Poland, and United Kingdom. It was also 280 sites, many of them in the United States. This trial for Lilly enrolled a phase 3 Alzheimer's trial in record time, and these investigators across 8 different countries were absolutely key to that. This is today's program. This is also on your online app. You could have seen it. The one thing that might be extra is the panel discussion question and answer session. I didn't see that in all the online material. Make sure that you stay for that. Don't think that you can leave. There's a couple housekeeping aspects here. We're going to have a QR code at the end of the talks, which will allow you to download all the slides. So this is hopefully going to save you picking up and taking pictures of the slides. I know that's a hard habit to stop at this point, but we are hoping that save you a little effort so you can watch the slides rather than trying to see them through your phone's scope there. So we're going to start obviously with clinical background and study design. Paul Solomon and then John Sims is going to do efficacy. Steve Soloway is going to do safety. Oscar Hansen is going to do biomarker results. And then Liana is going to bring us home with the clinical relevance. The other thing that you should know is that we're going to hold off on questions in the room until the very end. So no questions. We're not going to ask for questions. And then Craig is going to moderate the questions in the room. We also, however, will be able to take online questions anytime. So that is through the online web or the app. You can put online questions and start having them accumulate in there when you have it, so you don't have to remember them. And then we will be monitoring that from up here. Online questions are intrinsically anonymous, so if you want to be recognized, put your name and affiliation, and we will try to do that when we get to your question. All right? So we have a busy hour ahead of us, and one of the ways to save time is that since normally you always have a background slide, and instead of having a background slide in front of every talk, we said, gosh, why don't we just put one background slide in the beginning, and I'll take care of that. So here's our background slide. This is, the Donanemab program was in recognition of the fact that amyloid plaques is an early and essential event in Alzheimer's disease, and we believed maintained a role as accelerating that disease through the disease course. The Donanemab was selected to be against that insoluble, truncated form of amyloid plaques, and that is N3pG binding to that and nothing else. So highly specific for that. We believe that that would allow a rapid and robust amyloid removal, which was demonstrated in our phase 2 trial. Phase 2 was one of the first, was the first disease-modifying trial that had statistical significance on its primary, and which was the iADRS, as measured, measuring clinical progression on the iADRS. We're going to launch from there with the rest of the talks. But I want to remind you that everything you're going to see is with an antibody that binds only one thing that we know of in the brain, and that is insoluble plaques, and removes those plaques. And so I'm going to now turn it over to Paul Solomon to give us the background and clinical review.
Well, what an exciting time in Alzheimer's disease. The progress made, I think, over this past year is a couple of years is remarkable, and I'm very pleased to be here to share with you some of this. So there are my disclosures. Can I get a little further? Yeah. So I'm going to be talking about a study overview, and TRAILBLAZER ALZ2 is a randomized phase 3 trial in individuals with early symptomatic Alzheimer's disease. Aspects that differentiate this from other contemporary trials include both positive amyloid and tau criteria had to be met for inclusion, a lower MMSE score range that goes down to a score of 20 was allowed, and we believe it is the only trial that allowed superficial siderosis, which carries a little more risk for ARIA. We learned a lot from the phase 2 trial, and it informs us in the phase 3 trial design and modifications. Key differences from the phase 2 trial include expanding the tau inclusion criteria to include participants with high tau, removing a step down to 700 milligram dosing. If participants met amyloid criteria, they were switched directly to placebo. There was increased flexibility in treatment and discontinuation due to ARIA, and this allowed physicians at the sites to make decisions. And then there is a seamless 78-week blinded extension for participants enrolled in the placebo-controlled study. In addition, an open-label, unblinded exposure study with over 1,000 participants has just come to conclusion. This study was powered to test the low and medium tau populations as the primary analysis, set as a direct link to the phase 2, but also enrolled high tau participants so efficacy could be tested in a combined population of low, medium, plus high tau. For the overall study design, participants in the Donanemab group began with 3 doses of Donanemab at 700 milligrams before a dose escalation to 1,400 milligrams. You'd note that the participants on the 1,400 milligrams stayed on 1,400 milligrams until the end of the trial unless they met the amyloid clearance criteria, and that's based upon amyloid PET scans results from 24, 52, and 76 weeks. The IADRS was the primary endpoint chosen to replicate the positive phase 2 study. All other key outcomes were also included in the phase 2 trial. IADRS is a validated, integrated assessment that captures both cognition and function. All outcomes were controlled for multiplicity. Among the 8,240 participants screened for this trial, the 3 most common reasons for screen failure include tau PET, amyloid PET, and MMSE, all with about the same amount of screen failure. So looking at the disposition chart from left to right, Participants allocated to the placebo group are on top and the donanemab group on the bottom. You can see one of the key differences in this trial is active treatment only until plaque is cleared by study criteria. At 1 year, nearly 50% of all patients were able to stop donanemab treatment. Out of the 1,736 participants randomized, nearly 80% of the participants in the placebo group and 72% of the participants in the donanemab group completed the study. Baseline demographics were similar between placebo and donanemab within the low to medium combined population. The ApoE carrier rate is around 70% or greater. The symptomatic med use is a little higher in the combined population, which includes the high tau group, so this is anticipated. Across all the clinical scales, numerical scores were slightly worse in the combined population, and this is as expected. Amyloid levels were not much different between the subpopulations, but tau levels were, and this is, of course, by design. Plasma p-tau 217 levels were also higher in the combined population. There was broad inclusion of common comorbidities and concomitant medication use, which make this trial population more representative of the general over 65 population. So, in summary, TRAILBLAZER ALZ-2 is a phase 3 study designed to evaluate safety, efficacy of donanemab in individuals with early symptomatic AD with the presence of brain amyloid and tau pathology. A total of 8,240 individuals screened for the placebo-controlled component and yielded 1,736 randomized participants. The main reason for screen failures as distributed evenly across MMSE, amyloid PET, and tau PET. Baseline characteristics were balanced across placebo and donanemab groups, and the combined population showed greater impairment across the clinical assessments compared with the low-medium tau population.
All right.
Well done.
Thank you very much. So I'm now going to invite Dr. John Sims from Eli Lilly to present the efficacy results from the TRAILBLAZER 2 study. John?
Thank you, Craig. All right, my disclosures are that I'm an Eli Lilly employee, and the PET tracers that I'm discussing are used in an investigational purpose or manner. And I'm going to show you the next slide of the key primary and secondary outcome of this trial. This demonstrates that the Alzheimer's trial for TRAILBLAZER 2, phase 3, is a positive trial. And here you see in the low to medium, thank you. This low to medium population has delivered to the field the largest treatment effect to date. I'll come back to these results. Why was this the primary population of interest? What you see on the right is the phase 2 trial, which was the first anti-amyloid therapy to have a positive primary outcome, which demonstrated 32% slowing. And as previously mentioned, our goal was to reproduce this data, since reproduction would increase the confidence in this field. And as you see on the left, that represents the first reproduction of a phase of a primary outcome in our field. And other than the sample size, these results are remarkably similar. Now return to our results. As you will notice, for the larger sample size of the phase 3 study, you will see that we have now the ability to see significant treatment effects manifesting themselves as early as 12 weeks for the iADRS and as early as 24 weeks for the CDR sum of boxes. And we see good replication of relative slowing between these two outcome measures, with 35% slowing for the iADRS and 36% for the CDR sum of boxes. Now, if we move to the other primary that was gated, that's the combined tau population, which is over on the right. One thing you will note is that the y-axis has had to be expanded in order to accommodate that increased decline that is brought by the inclusion of the high tau population into this study. Now, the field has long had a hypothesis that pathology or advanced clinical stage should have an interaction with treatment. And I think as we go through the slides, that hypothesis is alive and well. And what you'll note here is that in the combined population with the higher pathology, there's a relative slowing that's actually driven more by a comparison of the rapidly declining placebo than a loss of absolute treatment difference. As we see in both these cases, we have an increasing absolute difference over time. This is illustrated even more dramatically when we look at the CDR sum of boxes. Here for the CDR sum of boxes, you will see again an expansion of the y-axis to accommodate that increased decline brought by the high tau population. And in fact, that decline is one of the greatest that we've seen in the more recent field. And here again, you see that there's relative slowing of 29% for the combined population when we compare it to that 36% decline in the low to medium population, that is indeed driven only by the comparison to that more rapidly declining population, because here there's almost no change in the absolute difference and an increasing over time. One of the questions that is hard to answer but has been always posed to the field is, how do you know this continues after your 18-month trial is over, or how do you know this continues after you've stopped dosing? So what we've illustrated here in a post hoc analysis is all the Donanemab treated patients who have now come off of treatment and moved to a placebo infusion, which is saline. Now, this was done in a blinded manner, and we continue to follow them, and that is a unique aspect of this study. And so this Donanemab population, on average, moved to a saline infusion at 47 weeks. And so after 47 weeks, the majority of these people are off treatment. And as you can see, over time, they continue to separate from that untreated patient population. Now, if we move to some other secondaries here, these are the components of the iADRS. And here for the low to medium tau population, you see again, we see treatment manifestations as early as 12 weeks for both of these components. And we see 40% slowing for the functional scale on the left and 32% slowing for cognition on the right. Now, if we include all of the secondaries across all the populations, we see a central tendency for the low to medium population to be around 30 to 40%. And for the combined population to be around 20 to 30%. And while the MMSE was not gated, we also see that it is statistically significant for both populations. Now, a robust finding in clinical should be supported by robust findings on various stat analysis, and here that's what we show. And I'll highlight the first row, which is the natural cubic spline, which was the statistical model that we used for the primary. And here you see over to the right that 35% slowing. That robustness is held even with the same statistical model when we eliminate all the potential unblinding cases. And then for donanemab, that would include all potential ARIA cases and all infusion-related reactions. And here that is maintained. And then I'll point out lastly on this, the mixed model repeated measures, or the MMRM, which is the more common outcome used in our field, and demonstrates a 40% slowing. So now what if we look at more at an individual level? This is our another gated outcome, which is pre-specified. Here is progression to the next stage of disease. These are very large step changes. This is going from MCI to mild, mild to moderate. Here, in order to meet the criteria of progression to the next stage of the disease, a participant needed to have 2 consecutive increases in their global scale in order to meet progression criteria. And here you can see donanemab treatment reduced that risk of progressing to the next stage of disease by 39%. This is also true for the combined population, where we see a 37% reduction. And you will note that there's a greater progression rate for the combined population given the greater pathology. Now, if we compare across all of the subgroups pre-planned, you will see that donanemab favors treatment and for any of the populations except for those that have small sample sizes. And we will highlight that this is true for the male to female comparisons. We will note that in the race and ethnicity, there are inadequate numbers providing very large confidence intervals and unstable point estimates across the 2 scales due to the inadequate enrollment of this population. And then I will highlight the baseline clinical staging. So think about this not from a pathology, but from the clinical typical staging. And here you will note that there are moderate patients by defining the MMSE. We only require the MMSE to be in that 20 range at screening. So participants could decline by the time they got dosed. And there is still a significant treatment difference for the moderate participant population. And there's a general hint that moving earlier is favorable, and I will show you more data on that. If we look at the ApoE genotype, you will appreciate that there is still a favoring of treatment for homozygous, although those confidence intervals increase due to the smaller sample sizes. And note that the non-carriers and the heterozygous are almost identical. And importantly, as we look at the tau PET, we see that high tau PET population, for which this trial was not powered to estimate, we still see numerically favoring treatments for the iADRS and statistically significant treatment effects for the combined population on the CDR sum of boxes. And you will note that the relative effect is also less, fitting with the hypothesis that this group is rapidly declining. Now, if we remove the idea of thinking about pathology, which was the key aspect of understanding the disease that the TRAILBLAZER program has been built upon, and we just go back to the more traditional clinical staging that we've been using in the field, this post hoc analysis addresses that. On the left, you will see a typical clinical staging population. This represents about 55% of our study. These are people who have 22 or higher on the MMSEs and have a CDR global scale of 1 or less. You will note that there's 38% slowing, a very nice effect with an absolute treatment difference of 0.66. There are, however, 45% of patients or participants on our study that don't meet those traditional clinical scale scorings, and that population still has a treatment effect, still significant. The relative slowing, you'll note, is less than the earlier stage of the clinicals, but the absolute treatment difference is still retained, and again, this is due to the comparison of a more rapidly declining population. We asked in a pre-specified but ungated analysis the same question. What if we looked in our study and asked how are the earliest clinical stage participants and the earliest pathology participants, so these are the low to medium MCI population, how well do they do? If our hypothesis is correct, they should do better, and that does indeed seem to be supported. That hypothesis suggests that moving earlier, we can achieve even better results with 46% slowing on the CDR sum of boxes and 60% slowing on the iADRS. In a simpler post hoc analysis, we asked this question just simply on age. What about earlier pathology? So this is low to medium pathology, and earlier age. And again, we get the same answer. a suggestion that if we are to make an earlier diagnosis for symptomatic patients, they will lose less and perhaps save more. So in summary, TRAILBLAZER ALZ 2, the phase 3, demonstrated that donanemab significantly slowed cognitive and functional decline in the early symptomatic stage of Alzheimer's disease, providing an important replication of the successful phase 2 study. And importantly, this efficacy extends into the broader combined study population, hopefully leaving no patient behind. Consistency was seen across all gated cognitive and functional secondary outcomes and across multiple analyses methods. Participants completing treatment regimen continued to separate from placebo. And this is some of the first data that is generated that really tests some of the hypotheses that pathology can inform a response to treatment and progression. And certainly, treating earlier in symptomatic disease is supported by a couple of analyses, both tau pathology analysis, some clinical stage analysis, age analysis. You'll see some other biomarker analysis that supports that when Oscar presents. And overall, this data holds some promise for studies in the preclinical stage of the disease, because that clinical progression score that I showed you on that CDR, that is the primary outcome for our preclinical study. And I think that bodes well, all this data, for us looking at the preclinical population. Thank you.
Thank you. Thank you very much. Thank you very much, John. I'd now like to introduce Dr. Stephen Salloway from the Asper Medical School of Brown University here in the USA. Here in the USA? Where am I? That'll be memorable. Anyway, and just to remind folks in the room that the QR code at the end will be up for all of these slides. And as well as people online, we are getting some really good questions through, so please keep bringing those forward to us, okay? And I'll try and remember where I am before I introduce the next speaker. Thank you, Steve.
Thanks, Craig. It's really a privilege and exciting to be presenting the safety data for the TRAILBLAZER Phase 3 program. Many of these advances we're hearing this week at AAIC have been years in coming, and so it's great to be a part of it. I have worked over the years in helping with development of anti-amyloid antibodies across many programs as a site PI, as a consultant, as a safety monitor, and also recently as an author for the appropriate use recommendations for aducanumab and lecanemab. This report will be about the safety outcomes in the combined population from the phase 3 trial. There will be a more detailed safety report prepared from a much larger exposure with donanemab in the near future when that data is available. The standard endpoints were obtained regarding safety. You heard from Paul about the MRI, safety MRI monitoring schedule. That was very helpful for detecting ARIA. And participants were excluded from the trial if the screening MRI showed more than 4 microhemorrhages, more than 1 area of superficial siderosis, macrohemorrhage, severe white matter disease, or presence of ARIA-E. The site PIs had discretion in management of ARIA, but they were given a guidance which is pretty similar to other antibody programs where patients with moderate to severe asymptomatic ARIA, the dose was suspended, and then monthly MRIs were obtained until the ARIA-E resolved and ARIA-H stabilized. And for any symptomatic ARIA, the dose was suspended with the same monitoring plan. There was a slightly higher rate of death in the donanemab group, 1.9% versus 1.1% in placebo. There was also a higher rate of treatment discontinuations, 13.1% versus 4.3%. And those were due to, you can see on the right side of this slide, the infusion-related reactions, ARIA-E, ARIA-H, and hypersensitivity. This is a list of the causes of death in both groups, in donanemab and placebo. Of note, there were 3 participants in the donanemab group with serious ARIA who subsequently died. None of these were prescribed anticoagulants or antiplatelet medications. 2 developed severe ARIA-E, 1 following retreatment after resolution of severe ARIA-E and stabilization of severe ARIA-H, and 1 had superficial siderosis at baseline and later developed a large intracerebral hemorrhage. Summaries of these 3 cases will be in the upcoming publication in the supplement. Consistent with the phase 2 program and other antibody programs, the most common treatment emergent AE was ARIA-E, occurring in 24%, and ARIA-H, occurring in 19.7%. There was a slightly higher rate of headache. There was an infusion reaction in 8.7%, superficial siderosis in 6.8%. Looking at the pattern of ARIA, 3/4, as we've seen previously, approximately 3/4 of cases of ARIA were asymptomatic and 25% were symptomatic. There was a small percentage of symptomatic cases or SAEs with ARIA-H. There were 3 macrohemorrhages in the donanemab group and 2 macrohemorrhages in the placebo group. The ARIA-E events were largely mild to moderate radiographically, and common symptoms were headache and confusion. ARIA-E tended to occur early with treatment, with the majority before up to the first 3 doses. ARIA-E resolved radiographically in 98% of participants with a mean resolution time of about 10 weeks. 6% of cases were recurrent with a higher rate in E4 carriers. And looking at the breakdown by ApoE4, as we've seen with other programs and in the phase 2, the rate of ARIA-E in non-carriers was 15.7%, in heterozygous carriers 22.8%, and in homozygous carriers 40.6%. So there is a higher rate based on ApoE4 copy number. There's also a higher rate of ARIA-H based on ApoE4 copy number, and you can see the figures there. 13 participants developed an SAE related to ARIA, and of those with ARIA-E, 12 were E4 carriers and 1 was a non-carrier. With SAE related to ARIA-H, 3 were ApoE4 carriers and 1 was a non-carrier. The rate, I forgot to mention this, but the rate of isolated microhemorrhage was the same between drug and placebo, but there was a higher rate of microhemorrhage in the setting of ARIA-E, as again we've seen in the phase 2. Now, in this trial, antithrombotics and anticoagulants were permitted. 9.8% of participants were on an anticoagulant. 38.8% of participants were on an antiplatelet agent. And interestingly, the rate of ARIA-E and ARIA-H was the same for both people on and off antithrombotics and also anticoagulants. In a very complicated case, one patient received TPA who had a severe COVID pneumonia and a hypercoagulable state, 6 days of TPA, and they eventually died of their COVID pneumonia, and they developed non-hemorrhagic infarcts, which were not thought to be due to treatment with TPA, but most likely due to the underlying COVID, severity of the COVID infection. In terms of immunogenicity and infusion-related reactions, overall, 8.7% of patients had an infusion-related reaction. They tended to be mild to moderate. Only in 3 cases were they serious, none with any sequelae. They tend to occur during the infusion or within 30 minutes of the end of the infusion, and they, again, were first seen between infusions 2 through 5. They led to treatment discontinuation in 3.6% of cases. As we've seen previously, 87% had treatment-emergent anti-drug antibodies, and 84% were positive for neutralizing antibodies. So, in summary, the safety profile was similar to the phase 2 findings and consistent with class effects observed with amyloid-lowering therapies. The mean changes in clinical laboratory values, vital signs, and ECGs, which I didn't show you, were similar across treatment groups. The most frequent treatment-emergent AEs that occurred in Donanemab include ARIA-H, ARIA-E, headache, infusion-related reactions, and superficial siderosis. The most common side effect, ARIA-E, was typically transient and asymptomatic, but serious and even fatal cases can occur. So careful safety monitoring is required to limit serious outcomes. Thank you.
Thank you very much, Dr. Salloway. Now, our penultimate presentation is Dr. Oscar Hansen from Lund University, who's going to be talking to us about the biomarker results from TRAILBLAZER 2. Thank you.
Thanks a lot. Thanks a lot. Yeah, happy to see so many of you here. So here are the disclosures. So first, I just want to remind you again that Donanemab only targets a modified version of amyloid beta that is found in the amyloid plaque, so it doesn't target soluble amyloid beta. And I will present different biomarkers relevant for Alzheimer's disease, so amyloid PET, that of course measures the amyloid PET plaque pathology in the brain, but also different downstream markers, including the results of effects of Donanemab on plasma phospho-217, GFAP neurofilament, as well as tau PET imaging. Yeah, due to the sake of time, I will not present here results on plasma phospho-181 and the volumetric MRI, but that will be presented tomorrow by Dr. Sims at 11:15. So again, just to remind you again that PET imaging was used as part of the enrollment process into the Donanemab phase 3 trial. So the participants were required to be amyloid PET positive, defined as having a centiloid of 37 or above. But also tau PET imaging was used as a requirement. So there should at least be some signal in an AD-relevant ROI that is at least 1.1 SUVR or then above to be part of a study. The population was also stratified into those with low median or high tau with another cutoff of 1.46. The plasma biomarkers shown here were not used as part of the enrollment process. So here are the results on longitudinal amyloid PET imaging. So to the left here, you see the results from the already published phase 2 trial, where Donanemab decreased amyloid PET with about 84 centiloids. And this was very beautifully, I think, replicated in the phase 3 trial, where we see a decrease by 88 centiloids in the low-medium group and 87 centiloids in the combined group. And you also see that there is a very rapid clearance of amyloid or reduction of amyloid, already significant at the first measurement time, that is at 24 weeks. The next slide is a bit more complex slide, but it's an animated slide, so you will see these dots moving soon. So the idea here is that I want to show you all individuals that received Donanemab in this trial, and we are looking at the amyloid PET values. So at the x-axis, you see the baseline amyloid PET values, and of course this will not change because these are baseline values, but on the y-axis, you see the amyloid PET values that will change with time. At the top of the slide, you see the time. So now we are at week 0, so before Donanemab treatment, so of course this is a straight line because now the values on the x and y-axis are the same. But now when I start the animation, you will see what happens to the amyloid levels during the first 24 weeks and then 52 weeks and 76 weeks. You see that if you compare to the baseline values, that is a straight line, people really decrease, the large majority of people decrease in their amyloid PET values. And the dashed line here is the cutoff used for abnormalities. So those that are below 24.1 centiloids are regarded as having a normal or negative amyloid PET scan. I will actually go back so you can see it again. And you can also download it and look at it at home and carefully, because I know it's not obvious. But what you also will see is that those that have lower centiloid levels or lower amyloid PET uptake at baseline will clear amyloid faster as expected compared to those that have higher levels. So here you see it again, the effect during the first 24 weeks, then 52 weeks, and 76 weeks, where the majority of individuals have negative or normal amyloid PET scans. So here, maybe in an easier way, we show the percentage of individuals that have reached negative PET scans, so it's reached cleared amyloid clearance. And you see in the low to medium group, already at 52 weeks, 71% of treated individuals have negative PET scans, and 80% then at 76 weeks. And this is very similar to the phase 2 trial, and very similar results you see to the right in the combined population. So in conclusion, the results from phase 2 trial were perfectly, I think, replicated when it comes to change in amyloid PET. So the next slide is the results in change in fractal imaging, so tau PET imaging, in 2 different RIs. And here I want to remind you that in the phase 2 trial, there was a difference between the placebo group and the treated group in change in tau PET imaging in the frontal cortex only. So here we see the results from an AD signature, an AD relevant region of interest, but also the frontal RI that was used in the phase 2 trial. But in this study, we do not see any difference between the placebo group and the Donanemab treated group, neither in the low-medium tau population or in the combined population. So this was a primary analysis. Now, ongoing analyses are looking into different regions, and also there are some post-hoc analyses looking into other differences, and there are some initial results that those individuals that had amyloid fully cleared have less tau accumulation over time. But that is not the primary analysis. The primary analysis here was negative. Another very important marker that I'm, of course, very interested in is phospho-tau 217, which is very associated with amyloid plaque pathology. And in the phase 2 trial, there were clear decreases in phospho-tau 217. And here you see very similar results. So in the placebo group, there is an increase in phospho-tau 217 over time by around 8%. But in the treatment group, there are decreases with 35 to 40% in phospho-tau 217, and measured here with the mass spectrometry assay. So very clear reductions. Work from different groups have also shown that plasma phospho-tau 217 is not only a diagnostic marker, but can also be used as a prognostic marker. So the higher the values, the worse the cognitive decline over time. And this is also shown here, where we stratified the population into those that had lower levels, middle levels, or higher levels of plasma phospho-tau 217 at baseline. And you see here in the change in iDRAS that those that had higher levels at baseline deteriorate faster than those that had lower levels. Here we show the results from the Donanemab treated group. So there was an effect of Donanemab in all these different subgroups here. But you also see that there is a relatively larger slowing of the cognitive decline in those that had lower phospho-tau levels at baseline. And of course, you can speculate that maybe it's better to come in earlier in the disease when you not yet have that much pathology, but it's just speculation. Very similar results were shown for CDR sum of boxes, where those individuals that had higher levels of phospho-tau 217 at baseline deteriorated faster. And again, the effect of Donanemab was slightly higher than, relatively speaking, in those that had lower phospho-tau levels at baseline. So neurofilament, as most of you know, is a marker more of axonal generation in the brain. And here we see a more complex relationship. So what we see is that at 24 weeks, there's actually an increase in plasma neurofilament levels in the Donanemab treated group, but then it decreases and numerically lower, but not significantly different compared to the placebo group. So there seems to be some biphasic change in plasma neurofilament. And this is consistent in both the low-medium tau population and in the combined population. In the phase 2 trial, there were also clear effect of donanemab on plasma GFAP, what was also here clearly replicated. So here again, you see in gray the increase over time in the placebo group, and then the decrease with donanemab treatment, about 20%. And this was shown both in the low, medium, and in a combined population. So in summary, the effects of donanemab were very nicely replicated when it comes to amyloid PET imaging, very similar results. Tau PET results were not replicated. There was a clear reduction in plasma phospho-tau217 and GFAP, just as in the phase 2 trial. And then there is biphasic change in plasma neurofilament light that we need to study more to understand better. And the volumetric changes, as I mentioned, on MRI and also to 181 results will be presented tomorrow. So donanemab significantly reduced amyloid plaques, plasma phospho-tau217 and GFAP at the earliest post-baseline study time points. So that was at 12 weeks, already at 12 weeks in plasma, and 24 weeks then for PET imaging. And over 66 and 76% of trial participants with symptomatic Alzheimer's disease achieved amyloid clearance at 52 weeks and 76 weeks respectively. The tau PET results from the phase 2 trial were not replicated, but we should also remember that this was the only gated outcome out of 24 pre-specified gated outcomes that was not significant in this phase 3 trial. As I mentioned again, please see the presentation tomorrow if you're interested in the results from volumetric MRI and phospho-tau 181. Thank you.
Thank you very much, Dr. Hansen. Now, our final presentation before we open the floor for questions and answers is Dr. Liana Apostolova from Indiana University School of Medicine.
Thank you so much. It's so exciting to be here today, and I'm honored to be on this panel. Here are my disclosures, and I have not participated as a site investigator in Indiana University in TRAILBLAZER ALZ and at TRAILBLAZER ALZ 2. So I will be talking to you about clinical meaningfulness, or what is important to our patients. When we talk about efficacy in clinical trials, the metrics we use to communicate scientific findings are not easy for our patients to understand. So if we think about the early Alzheimer's disease population and ask our patients what is most important to you, they invariably would say memory loss and loss of independence. And when we ask them about what the most desired outcomes would be for them from disease-modifying therapies, the number one is improvement or reversal of memory loss, followed by stopping or slowing down disease progression and maintaining ability to function independently. There are some others that are also mentioned, such as emotional well-being, physical and mental health, safety, but for the purpose of this presentation, I will largely focus on memory and functional independence. So here is a hypothetical presentation of a disease-modified trial with the drug depicted in the dashed blue line on top and the placebo or natural disease scores depicted in the black uninterrupted line graph on the bottom. What we see with the horizontal line between the two therapies is the two groups is the effect size or the efficacy in the trial. And that is typically expressed as difference at a certain time point between cognitive outcomes or functional outcomes, or slowing of progression or changing the slope of progression over time that is observed for the treatment group compared to placebo. And that slowing of progression in TRAILBLAZER ALZ 2 was 35%. However, how about depicting this as a time saved? And by doing that, we can not look at the difference on the y-axis, but the difference between the groups on the x-axis, and the x-axis measures time. Here's how the data looks in phase 3 TRAILBLAZER ALZ 2 for the primary outcome measure, the iDRS. We can see that the placebo group reached the endpoint, the cognitive endpoint that was observed for the Donanemab treated group 4.5 months earlier. In other words, there was 4.5 months of time saved for the Donanemab-treated patients for iDRESS. And here are the sensitivity analysis for iDRESS and also CDR sum of boxes. The savings for CDR sum of boxes was 7.5 months. Now let's look at the magnitude of the difference between the two therapeutic groups at the end of the trial. And for CDR sum of boxes, that difference was 0.67 for the low medium tau population and 0.7 for the combined population. Is that a meaningful difference? Here I'm showing you the clinical dementia rating algorithm. And just to remind you, we're going to talk about memory and functional outcomes. So I'm going to focus on the following domains: the memory domain, judgment and problem solving, and community affairs. In terms of memory, a difference, a half a point difference between questionable to mild stage of the disease is a difference between consistent slight forgetfulness or benign forgetfulness and moderate memory loss interfering with activities of daily living. In terms of judgment and problem solving, it is a difference between slight impairment and moderate difficulty in handling problems, similarities, and differences. And as we look at community affairs or day-to-day functioning, the difference goes from slight impairment in those functions to unable to function independently. Obviously, all these three examples are clinically meaningful outcomes for our patients. Now let's look at the data another way. How about looking at non-progressors, proportion of non-progressors measured on CDR sum of boxes? And here you see that we're showing data, all statistically significant difference between the groups at 24 weeks, 52 weeks, and 76 weeks. Let's take a look at 52 weeks, which is a year after treatment has been started. 47% of patients treated with Donanemab and only 29% of patients treated with patients on placebo did not worsen on CDR sum of boxes. If we were to look at disease stages, and that is measured well by CDR Global Score, there are 5 stages recognized: stage 0 or asymptomatic individuals, stage 0.5 or MCI, and then with a score of 1, 2, and 3 are the mild, moderate, and severe dementia stages. So how about if we look at the proportion of patients and the likelihood of patients to not progress over time to the next disease stage? Here these graphs, these time to event graphs show placebo group in gray and Donanemab treated patients in green. And what you see is there was 38.6 lower risk of progression to the next clinically significant stage of the disease in the Donanemab treated group compared to placebo. How about within patient changes? Well, what is a meaningful within patient difference? And that is an outcome measure. There is an outcome measure result that patients, care partners, and physicians deem to be clinically significant. And for the iDRESS in the MCI group, that is 5 points or more. And in the dementia group, 9 points or more at 2 consecutive visits. For CDR sum of boxes, it's 1 point or greater in MCI, or 2 points or greater for dementia patients at 2 consecutive visits. And here are the results from the phase 3 TRAILBLAZER ALZ data in the low-medium tau population. What we see is that there was 36% lower risk of a meaningful within-patient change over the 76 weeks of the trial with the Donanemab, in the Donanemab group relative to placebo. And in terms of CDR sum of boxes, the difference was 40% lower risk in Donanemab-treated individuals. Please allow me to summarize the data I presented first. I hope that with this presentation I convey to you that Donanemab is slowing clinical decline by 4.5 months for iDRESS and 7.5 months for CDR sum of boxes. Looking at stability of cognitive symptoms, we saw that at 1 year, 47% of Donanemab-treated patients and only 29% of placebo-treated patients had no progression as measured by CDR sum of boxes. There is lower risk of advancement to the next clinical stage as measured by CDR global, and the lowering of the risk was 39% in the Donanemab-treated group. And there is lower risk of meaningful within-patient change, 36 to 41%, as we look at iADRS and CDR sum of boxes. And as the last speaker, I get to summarize the findings from this whole symposium. First and foremost, TRAILBLAZER ALZ 2, our phase 3 study, replicated the phase 2 results and showed that Donanemab significantly slowed disease progression in individuals with early symptomatic AD. There was consistent efficacy across populations, cognitive and functional secondary endpoints, and across multiple analysis methods. Although participants in the low, medium, and combined population show similarly the treatment to be efficacious, the effects were greater in the low, medium tau population, which conveys a message that we need to treat as early as possible. The safety profile of Donanemab was similar to the one seen in the phase 2 trial and consistent with the class effect of side effects seen with the monoclonal antibodies in general. Donanemab reduced amyloid plaque burden, p-tau217, and GFAP at the earliest post-baseline measure of these biomarkers, which was 12 weeks for plasma and 24 weeks for the PET measures. Over 50% of trial participants achieved amyloid clearance at 1 year. The observed benefit seen across populations, clinical outcomes, and analytic approaches reinforces the promise of Donanemab as a treatment for early symptomatic Alzheimer's disease. Thank you.
So thank you very much, Leanna, and thanks to all the speakers. Actually, we've managed to find 5 times for more Q&A. We've also got quite a few questions online with Mark. So just before we go to that, this is the paper which is now published from the findings of the TRAILBLAZER 2 trial. And I'm just going to show you 2 QR codes. On the right, if you navigate to that QR code, that will allow you to download the manuscript and supplementary files within that. And then on the left is the QR code we promised you for all these slides. So you can take your phones out now.
Glad we remembered to put that up there.
You're all paying attention. It was great.
No, that's okay. Give them a minute. No.
So let's open up the session both from the... Can we actually have the house lights up? It makes our lives a bit easier up here in the panel if we can actually see what's going on. They've got spotlights on the spots. I'm going to go to number 2 first. Sorry. If you could just, by the way, could you just introduce yourself, your institution, and then be concise and precise with your question? That would be fantastic.
Yes, thank you. I'm Dr. Shah from Iowa, USA. I'm a geriatrician in the practice, and the question is about the effect on the minority, especially African American patient populations. So if you can explain the less effect on the black patient population.
Okay, I think that maybe to you, Steve.
Yeah, I think that.
John, sorry.
I would not conclude that there's less effect. What I conclude is that we had an inadequate sample size to draw a good conclusion. The point estimates were on either side, depending on the scale that you looked at, and the confidence intervals were very wide. We clearly recognize that we did not enroll enough representative populations for the U.S. and other countries. And we did have an ongoing large safety, which is about 1,000 participants. So we do have much more information as far as safety, and we doubled the amount of people that we enrolled. It still needs work, and we continue to work on that even with the TRAILBLAZER 3, which is also achieving better enrollment. But we do note that, like has been presented a couple of times, we had 2 pathologies that were required for enrollment, and we see when we screen with those 2 pathologies, both amyloid or tau, we need to screen 4 times the number for the amyloid and 4 times for the tau. So it does create an additional challenge for us.
Thank you.
Okay, to number 3 over here.
Yeah, Chris Van Dyke from Yale. First want to say congratulations and thank you for this study and these results. In particular, thank you for characterizing all of the participants by tau PET and really demonstrating that that's important with regard to efficacy. However, I think this kind of enrichment strategy, I think it points to one of the problems with using enrichment in a pivotal trial. In this case by tau PET, it isn't so bad with the high tau because at least they are studied, and so we do have the benefit of seeing how they did. But I think it's really unfortunate with the low tau PET. If I understand, 25% of people were excluded for, low tau. The same people who were included in the aducanumab and the lecanemab trials. So that not only makes it hard to compare these results with other studies, but especially it leaves us really in the dark in the clinic. Because we're going to see the people with those 25% with very low tau.
And your question is?
And the question is, here's the question. So do you think that people with low tau shouldn't be treated at all? And if so, what's the evidence for that?
So John's leaning forward instantly to take that one. So John.
Actually, John, go ahead.
I'll take it. Chris, good point. So we don't think people with no tau should be treated. We think that population sits in our TRAILBLAZER 3 preclinical population. Those people, by and large, have no tau. I think the challenge is if we're talking about a symptomatic patient population, first of all, I don't think tau is necessary to treat a patient, right? So I think it informs the physician, but it's not predictive of the outcome of that treatment. So I do think it is informative, but not required.
Mark.
The other thing I just wanted is the concept that all of the data we have is going earlier gives a higher efficacy, having that low tau. But one of the things that, just to clarify our language, and maybe I'm repeating some of the things John said, but the group we did include was low to medium tau. It was essentially no tau that was not in this. Definition of Alzheimer's is typically, amyloid and tau, so I think that's a fundamental concept. We wanted to make sure people had the disease and actually declined. But with people who are clearly impaired and have amyloid positivity, I think we're showing that the earlier you can catch it, including, very small amounts of tau, would probably be more beneficial than what we're seeing here. So I'm now going to pivot. Oops, no, fortunately it refreshes. There's now like pages and pages and pages of questions now.
They've read the paper
so
now.
one of the ones, actually this needs to be for John. Are we following those patients who cleared more than just the 18 months at the end of the trial?
Yeah. So I think what was pointed out is there is a long-term extension to the study that's 18 months. It's an exact replica of the first 18 months of the double-blinded placebo-controlled trial. So it's somewhat complex, but it's still ongoing. It is also blinded, so we've continued that blind. Placebo patients will get donanemab. Those people on donanemab who didn't clear will continue to get donanemab, so that we'll understand how long it takes to clear some of the more resistant folks. And those people who were cleared and on a saline infusion will continue to follow them. So we'll have up to 3 years of follow-up with that long-term extension, and we continue to do some of that modeling and understanding of the disease after treatment.
Thanks, John. We'll go way over to our left here, number 4.
Thank you. Anna Pereira from Mount Sinai in New York City. Thanks for the presentation. This is a question for Oscar. Oscar, you mentioned you measure the phosphatide-217 through mass spec. I was wondering what your results were with immunoassays and how that correlates with both amyloid and cognitive performance, and could you use potentially phosphatide-217 as a surrogate marker of removal of amyloid and responders to treatment?
A lot of very good questions. Exactly. So in the phase 2 trial, it was used the Lilly developed immunoassay now, and it was very similar results, even though not as pronounced. Now we're using the mass spec method. It was more pronounced differences. Important here is that it's phosphatide-217. It's not the ratio, because also the non-phosphorylated tau is also decreasing with treatment. So it's 217 alone. Your question when it comes to if we can use 217 as an outcome measure to see if an individual is responding or not is very interesting. But the data we have seen this far, that has been published by Mark and others suggest that it's maybe not completely straightforward, because you can have quite clear reductions in amyloid PET, but not always similar changes in phosphatide-217. So I think there need to be more research. Maybe we need to combine different markers and so on. But now I think still we need amyloid PET imaging to see who has reached amyloid clearance or not.
Thanks, Oscar. I'm going to come to number 7 and over to 6 here.
Hello, Pieter van der Veer from the VU here in Amsterdam. I would like to ask if you could speculate on why there appears to be a relatively stable absolute difference in change in cognitive measures between intermediate and high tau and not a stable percentage change.
So I feel that's another one for you, John, but does anybody else want to lean forward and take it? Are you happy to, John? Yeah.
Short answer is I don't know why. Yeah, it was consistent almost wherever we looked, right, that we saw at whatever scale that there's some fairly consistent absolute change. And so I think it's an important finding that we'll need to understand the implications, because a lot of times we talk about relative slowing and percent slowing, and it might be dependent when we use those numbers to understand, you know, who's the comparator, right, that's, which is not atypical for most other therapeutics, is to understand that relative versus absolute. I think this is the first time we're having this conversation in the field. Other areas of medicine have had this conversation and have a better understanding of these. I think time will tell.
Thanks, John.
Thank you.
Please.
Barry Greenberg, Johns Hopkins University. First of all, I want to say thank you. I do have a question, because I'm curious about something. I've seen a lot of data about the low to mid tau and then the full population. I have seen no data on the high tau, in exclusion of the low to mid tau. Can you give us some information on that population?
Yeah, so that subgroup is not powered for, but you will see we put it all in the paper. So if you go to the paper, all that data is sitting there. You'll see it.
Okay, thank you. I'm just going to keep working around in a clockwise fashion too.
Yeah, congratulations for the presentation. I don't think that including intermediate and high tau is a weak point, but a strong point, since about 10% of amyloid positive patients with cognitive decline might have other disease, so being a false positive. So I think it's a strong point. Yesterday also on the updated NIH criteria for Alzheimer's disease, there were much criticism about removing tau positive necessity need for the diagnosis. And also was shown that about 15% of amyloid positive PET don't progress after 20 years.
Okay.
So I think it's a strong point, just a comment.
Okay, thank you. Thank you for that. Yeah. So, no one at 3, so actually way over number 4, Professor Barkov.
Thank you, Craig, and thanks, congratulations to everybody for a very positive trial. This is Frederick Barkov from Amsterdam. You showed various graphs where I had the feeling that the curves after an initial separation were going down in parallel. And I would like you to speculate whether that may be related to the fact that you discontinued the drug in some people who had amyloid lowering. Also because on the nice animation that Oscar showed, the most points were going down. There were actually a couple that I thought were moving up again. Can you speculate about that?
Yeah, I'll take it. Actually, if you noted, we put specifically the numbers all the way along the time frame. You can see that they are constantly increasing and separating. There's a little bit of eye play for the curve, particularly for the curvilinear one. And if you look at the CDR sum of boxes, which tends to be a very much more linear, you can see that none of them are parallel. They're continuing to increase. With regards to some of the up and downs, yes, I think what's very fascinating is as we look at the individual data points, you start to see some other patterns. So some of those, if you, wish we could all sit here and play it over and over and over again, you could kind of see. But you'll notice that some of them, went up, and the next time you clicked it, they went down. And so I think some of it is just, they probably weren't changing a lot, and it was variation in the measurement, which certainly happened.
Yeah, but, and I know John said it, but it seemed like such an important analysis. When you look at those people who went off drug, you get continued widening between placebo and that group. So even though they went off drug, they continued to widen. And they only went off drug when they were very low. I mean, they were truly low by our criteria on amyloid. So they were negative on amyloid. In general, as you mentioned, one's a curvilinear. Several people have asked this online as well, so that's why I'm elaborating. This issue that the CDR sum of boxes looks like it's two straight lines slightly diverging. And the other ones look like they're coming down like a curve. But just remember, in my way of thinking about it, most people, Alzheimer's is an accelerating disease. Things get worse and then they get worse more rapidly. In a way, the iDRS is a more linear representation of the actual things that are happening. CDR sum of boxes, it has sort of a built-in stretch phenomenon, so that as you move out, it's sort of a nonlinear. It's adapted to the way Alzheimer's patients decline, so it has a tendency to look linear in their decline. So what happened is that we showed a very nice linear phenomenon, and we showed a very nice curvilinear phenomenon in the one that gives a curvilinear approach. So I don't think it should be surprising, but that's why we had that little animation where as we go down in both iDRS and CDR sum of boxes, it just kept expanding. So I think it seems very convincing. But you're right, when we show individual points, you are noticing noise, someone is not responding to drug, they will bounce up and down in their amyloid scan. That's what happens.
The nature of PET scanning. Thanks for the answers.
Thank you. Oscar, Oscar, do you want to add anything to that?
No, I fully agree with that. Of course, we have some variability, retest variability now when doing repeated amyloid PET scans. So there was no one really bumping up a lot.
So, Steve, online there are several questions having to do with, if you could review a little bit on the ApoE4 status of the deaths and the relationship of the ARIA to ApoE4 status. And were they ApoE4 positive, et cetera?
Yeah, so now that the paper is published, in the summaries, 2 of those 3 cases were ApoE4 carriers and 1 was a non-carrier, and I think the 2 were heterozygotes.
Thank you. So we're going to go over to, I think it's number 8. I'm struggling now.
Thank you.
I'm just going around.
Raquel Gardner, Sheba Medical Center, Israel. This is another question for Oscar. Regarding the blood-based biomarkers, specifically NFL and GFAP. So we now know that GFAP is an FDA-approved biomarker of acute traumatic brain injury for diagnosis that elevates in about 12 hours of acute brain injury. And NFL is a marker of subacute injury that goes up over a few days. So I'm curious if you've looked to see whether either GFAP or NFL elevate in the context of ARIA. And particularly, I would hypothesize it should certainly elevate in ARIA-H, and specifically in symptomatic ARIA.
Thank you.
It's a very good question, because We don't have that analysis, at least I haven't seen it yet, but considering that neurofilament was increasing at 24 weeks when the ARIA frequency is higher early on, that might be, but we don't know, at least I don't know yet if that could be the explanation, but I wouldn't be surprised. With GFAP, there doesn't really seem like that. Now, GFAP really go down already at the earliest time points, even there is some ARIA, but those sub-analysis needs to be done, and I agree with you. That would be very interesting from a biological point of view.
And screening purposes at lower cost. Thank you.
So we've got 5 questions in the room I can see in a minute left, but we can go over a little bit, so I think everyone who's up will get a chance to ask. So sorry, number 7, yeah, hi.
Thank you. Congratulations on replicating this very innovative design. My name is Emo from Merck. I have 2 quick questions for Dr. Sims. So if I remember correctly, the MMSE exclusion criteria upper limit is 28, and there was a post hoc analysis using MMSE up to 30 at the screening all baseline. I'm wondering how that was done. And the second question is about the 84% of patients on Donanemab developing neutralizing antibody, anti-drug antibody. Was the effects consistent?
Yeah, I'll go in reverse order of your question. So yes, since phase 1, we've known that almost everyone makes an anti-drug antibody, so that's been consistent. We follow that, and it's actually is a little lower than it was in the phase 2, actually, in the study. With regards to the MMSE, I'm not quite sure I understood your question, but let me clarify the MMSE analysis. So MMSE was scored at screening, and that was what was required to enter. We did not require that MMSE at baseline to be the same score, and the reason for us not doing that is it causes an entry bias on that score. And so some people would drop below their score. Some actually went above their scores as well. So we used the baseline score for any change analysis. The MMSE that we used for calling an MCI, that was not post hoc, that was a pre-specified analysis. And then the other, I think, place where you might have seen it was on the subgroup analysis, which are also kind of pre-specified subgroup analysis. So everything was pre-specified, but none of those things were actually gated.
And on the anti-drug antibody? There was a question about the anti-drug antibody.
I answered that.
First, he answered first.
I was talking to you at the time, obviously. Okay, so up to number 6.
Jacobo Minzer, Medical University of South Carolina. Question. Are the individuals where the amyloid load was reduced to 24 or less centiloids were the same individuals that did not progress? Or there was at least, and the second part of the question is, was any difference in the clinical outcomes in terms of not progression, between the individuals that were at different stages of the disease?
I think that's you again.
We didn't do the first
We've not done that particular analysis, that very specific subgroup analysis, so I don't know the answer to your question, sorry.
I think that will be critical for clinicians, because if we can reduce the level of amyloid to 24 and those people remain stable, now we have a landmark.
So, I couldn't agree with you more, although, the amyloid is, at an individual level, it's not the greatest predictor of outcomes, right? I think we've learned that. So I would be surprised if it was really dramatic effect. We haven't done it, and then maybe there's a relationship, but I don't know.
We're in our last minute or two. There's 1 question online and 2 from in the room. So,
great. Thank you very much, and congratulations. My name's Cindy Lemire from Brigham and Women's Hospital, and I'm a big fan of Pyroglue, so congratulations. I also just wanted to ask, did you see any correlation between the speed of amyloid clearance and the rate of ARIA? And in those patients that actually went down to baseline, or negative amyloid PET scans, did those patients ever show any recurrence of ARIA after treatment stopped? In other words, do you need the antibody there?
I'm not sure I know the answer, but my understanding was that What we saw in the TRAILBLAZER 4 trial, which compared aducanumab and donanemab, was there didn't appear to be a change in ARIA with increased amyloid lowering. And so that's my understanding of the analysis so far. I don't know if you have any further.
So you're asking some really good questions in science we're trying to solve, right? So within a molecule, it looks like ARIA and amyloid lowering kind of go together. As ARIA goes up, so does the amyloid lowering. However, between molecules, it does not appear to be so consistent, right? So when we run the aducanumab and donanemab, we have, quite dramatic lowering of amyloid, but not the same levels of ARIA between those two molecules. So it's probably more complex.
Okay. And do you ever see the recurrence of ARIA after stopping treatment?
So I don't. That's a good question. I don't think so. Maybe there's a case or two, but nothing that comes to my mind. Right? I think we know that ARIA does happen spontaneously. I don't think I've ever asked that question of.
Okay.
Yeah.
Thank you.
So we've got one more question in the room, one more question online, and then we'll close the meeting.
Hi, my name is Maria Isaac Tome, and this question is for Professor Liliana Postauban. One is, thank you so much. I am a clinician and a regulator. I will not talk as a regulator, but as a clinician. And I think it was one of the best presentations about what is clinical meaningful. And keeping in mind that this is going to appear all over, and keeping in mind that I have patients, I think it's really thank you for that, because we will have people knocking in the door, and really we need to explain what it means for them. Thank you.
Thank you. Oh, thank you.
Final question.
So there was one question online that was basically a what next? Combining two questions actually online. Well, they are basically should we go earlier? Why aren't you doing tau equals 0? And I did want to point out, from a programmatic point of view, we have a preclinical Alzheimer's trial, a trial enrolling patients without symptoms, and tau PET we know from experience, tau PET would be very, very low, if not zero, in many of those patients. So we are looking at the effect of donanemab to slow progression from an asymptomatic patient into a symptomatic patient. So that trial is ongoing, and we're very excited about that. Perhaps I can say we're even more excited about it given the results we just saw in the last few months. So that is an area that is worthy of increased study, and we're doing it. So more questions, more time?
I think we probably maybe just one more question. I've just been allowed one more question from my co-chair.
Cortin, Tel Aviv. Thank you very much and congratulations. The change in the slope was very interesting, but showed that there is still a decline also in patients who received the drug, and the reduction of the slope was maybe 20–30%. But it means that these patients will continue to decrease in spite of getting the treatment. And the assumption or the point that was made that the earlier the better means also that as the patients will continue to decrease in spite of getting donanemab, they will reach a state in which the drug will not work for them.
So they do continue to decline, right? And I think that highlights why we're all here. We do need more medicines. I think we've seen, at least consistently, that none of the current explored therapies are actually lowering the tau itself. We've seen some suggestion of slowing, but they're all going up. There's other things that need to be targeted in order to really bring this disease to a halt. And certainly there are people where the benefit starts to reduce. Where that level is, I think we need to figure that out for each individual therapy and each stage.
So thank you, everyone. I think we'll draw a line now under the Q&A. And before I pass to Mark to say some final words, I just think you'd probably like to join me in thanking all of the speakers in this fantastic and transformative session. Thank you.
No, we just need to close the session. We're probably going to be kicked out of here in a minute. I just want to say, it's been such a journey, and I think the one message I'd like to leave you with is that I think the data that we've presented here should make it very, very clear now that removing amyloid plaques from the brain can provide statistically significant and meaningful benefits for patients in a trial like this. So data from this trial, I think, makes that really, really clear. And I just feel that this is so much time and effort to be able to demonstrate it in such a clear way. Thank you for all the people in this room that have helped, but all the people who have contributed to this field in this incredibly important way. The other one is also a field statement, which is we have now added dramatically to the supporting, diagnosing early, and getting people ready for treatment early. And I think it's so important that we take that message and really think about how we can do something about that. I can now say that we have submitted for approval at the FDA, and over the next rest of this year, we'll be submitting in other geographies around the world. We expect to hear from the submission we've already done by the end of the year from the FDA. So we are moving rapidly as we can to see if we can make this drug available. But I think as a field, we need to make sure that we figure out ways of getting patients diagnosed early, evaluated, and risk and benefit for treatment as soon as possible in their progression. Going early should be able to slow this disease even more than we have shown here. So we're very, very excited about it, and we're very excited to be able to bring this to you today. So thank you very much for your attention.